are talking about the choice of the so-called ideal restoration. And starting with a short history, you can see that implantology or osseointegration started in the 60s. We went through the birth to infancy, adolescence, and we are now in the maturation and consolidation phase. And that's why the subtle changes are happening and things are improving. If we are looking to PROS in specific, we had changing from, we are looking today from impression taking, normal analog, to intraoral scanning. We went from waxing to CAT and from casting to CAM. This is still a movement happening. We came from metal and plastic, went to PFM, and are going now to zirconia. And if we are looking to the fixation, we came from screw, went to cement, and now we are going back to screw sometimes again. So a lot of changes are happening. Maybe let's take another one, a big one, the team approach, whereas in the beginning it was a surgical procedure, a totally surgical procedure. Today, this is more a team approach we are doing. And this reminds me to the 80s, to the birth, when we treated our patients. You see an old case, an edentulous case, where everything had been done by casting. Gold was the number one material that was used, gold for the bar, gold for the overdenture too. And at that time, there were other different rules. Very long implants were placed, bicortical stabilization, interforaminal placement, all these aspects that have changed. There is no time to go into that. If we go about 20, 30 years later, today, we can place implants where they are needed. We have, again, an overdenture construction. We can do it step by step, but we can use now different materials, and we can do our restoration without any metal by only using zirconia. You see a fully zirconia bar, and what you can also see is a fully zirconia overdenture that has been fabricated without any metals. And you can see that you can elaborate it in a very perfect surface for less plaque adherence, and also aesthetically when we can achieve a very good result. This is the case intraorally, where you have a full zirconia bar and a full zirconia overdenture. Of course, there is still metal left, and these are specific cases we were doing in the clinic, where we did the transformation of overdenture cases with attachment, with two attachments, to an all-on-two implant solution in very old patients where the forces are very reduced. And of course, you can mill here by titanium the bar, very stable titanium bar, and then have a fixed restoration. But I remind again, it's an experimental solution. You can see it here, where a reduced dentition or a premolar dentition in these cases. Now the question is, what is ideal? Ideal for whom? There are a lot of questions. We can't answer all of them. What is the minimal knowledge to have this ideal restoration? And what is the pathway or the treatment planning way to do this restoration? Some of these aspects should be discussed now. And of course, there are a lot of factors to be included. On the one side, the dentist, on the other side, the patient, and the third, especially in PROS, the team member is the technologist. And we together, all together, have to select the right biomaterial. We have to base a checklist for the treatment plan, have a clinical concept, and we have to rely on evidence, on long-term behavior, long-term results, and of course we have also to organize the maintenance. Perfect, what means perfect or ideal is the best possible that we can achieve, or can only be something that is highly desirable but we can never reach. So ideal is something that is not very defined very well scientifically, but is something that we want to have an aim and to reach at. And we have to remember that the ideal for every prosthodontist, this is true, the ideal is the restoration that I never did, because the natural teeth still are the best, and we have always to compare that with the situation of the natural dentition. So at the end, as a prosthodontist, our ultimate vision should always be that we make ourselves obsolete. Sounds very strange in an implant meeting, but in the background we have always to remember that. And having this as a base, there should be a certain mission. The mission includes that we want to keep teeth for life as a base, that we want to adhere to biology, and that we want to refrain from over-treatment. This is especially true today because we have a lot of new technology coming in, and this is a certain danger that we are going for over-treatment. The principles to have these missions are minimal invasivity, and minimal invasivity means today, on the one side, adhesion, on the other side, implantology, where we can interfere locally where, as a prosthodontist, where single or multiple tooth are left. I don't want to go into all these aspects, but you can see maybe the last one, to strategically postpone invasive prosthodontic to the older age, because people get older, and we should have for the older age all the menu card of implantology and prosthodontics aspect still available for these people. Of course, there must be a concept how you go to the treatment plan. We have already seen that this morning in the clinical cases, where you go systematically through. You have your treatment goals. This can change. You have to confirm or modify them when something happens in between, and you have always to reevaluate, re-examine the whole situation, maybe together with your colleagues, but especially with your patient concerning the cooperation and the prognosis. And the whole thing includes the dental hygienist, and on the other side, the dental technician. So it's a teamwork, again, that we have to fulfill. Here, I point specifically to the team approach as a prosthodontist today, because it's very important. We fail without any team approach if there is not a very good relationship between the prosthodontist and the patient, technologist, and vice versa, because there is communication, there is interaction, there is trust, there must be understanding, there must be partnership, and there must be acceptance. Without all these parameters, we will not be successful. And the patient must be included in the prosthodontic treatment and also implant treatment to understand what is happening, because he is part of the final success that we will reach. And this is shown here together with the technician, where the result, the mock-up for additive laminates in this case, can be only decided for the final solution if the patient can see, accept, and follow what is done during the treatment. Of course, we can have the menu card and look what is available in prosthodontics. We have fixed solution, we have bonded solution, we have removable solution, but the decision-making process relying only on the different solution, this is not the ideal restoration. This is the easiest part because this part is, the decision-making process is basically made by economical aspects. In most cases, the economy already decides in which direction I go. But each direction, again, has a lot of other possible small modifications that can be done. Here, as an example, something that is forgotten in some cases in young patients, where you have the resin-bonded retainer with full zirconia retainer, a very nice solution for very young patients before they go into implantology. And although it's considered a provisional restoration, especially in these young patients, it can be considered today as a semi-definitive solution until we have a better way to place the implant or a better age to place the implant. So the decision-making process is quite complicated. On the one side, the systematic, comprehensive, and sophisticated evaluation of the case. On the other side, science, evidence, but also common sense and clinical experience that has to be included in the decision-making process. The biomaterial selection is one aspect. We have to respect the characteristics of the biomaterial, but also to see the challenges worldwide for the biomaterial. But at the end, minimal invasiveness is a main parameter that has to be respected. Taking, for example, ceramics today makes it already very difficult. On the one side, I can look at the physical properties. They are good anyway for all the ceramics. I can look at the long-term success. It's a little bit more difficult because new ceramics are developing every day. And if we are having the aesthetic factors, it's even more complicated because then the single case is deciding more and more. So for single crowns, we can use today whatever we like, where we are best off, but for fixed long span solution, PFM is still the solution of choice because of stability. Here you see a typical case where a lot of teeth had to be extracted because of endo and iatrogenic failures. Implants were placed in this case in the upper jaw. The minimal number of implants, you see only 2 on both sides. The plan was, or the aim was, to have a cantilever solution on both sides. And you see the combination of PFM, because of cantilever, in the posterior region and full ceramic in the front teeth on their own teeth. I can't go into details further, it's just to show as an example. But today again, PFM has a big competition from zirconia. You see a big case in the upper jaw, full implant case, where full zirconia restoration is made. The nice part with the digitalization and zirconia that is combined, of course, is that we can already have the provisional made by the digital wax up. We can try the provisional in, and then we can copy the provisional and make the final restoration as it was made in this case for this lady. So it's very nice today how we can play with this material, and we can even combine material. We can have an abutment out of zirconia, as you can see here, and we can cover it by composite, because if it's screw retained, maybe some years from now we would like to enter again, and it's easier to have a composite head here on the zirconia abutment that I can take away. And because it's a digital cover, everything has been done digitally, I can only remill it again or reprint it again and have it covered again in this way. So it's really nice to have all these solutions. As we have already seen very clearly this morning, also as a prosthodontist, I have to know precisely my biological basement, and we start as the gold standard from the natural tooth, the periodontium, where we know we have a very sophisticated base, and we know how to treat it. We can diagnose it. We realize if there is any pathological process going on, or if there is absolutely a healthy situation. It's not so easy if we are going to implants, because we have a scar tissue. It's not anymore a very sophisticated tissue. It's only a scar tissue, mainly based on collagen, as you can see. But we have here also very nice vascularization, but the whole tissue is different, and we have to accept that even if we are going for aesthetics. And that's why it's more complex, and it has been very nicely shown by Nitzan this morning how complex it is, because we are not dealing with a periodontium. We are dealing with scar tissue that has to be modeled and modified, taking time, surgical intervention, and so on, to get to a similar result as with a natural tooth. And this picture very nicely shows the difference between the periodontium and the implant situation. So if we want to have an aesthetic success, of course, the quality and aesthetics of the restoration itself is very important, but also the performance and reliability of the implant system, as we have seen, is of high importance. And going back to history, you can see still today, we want to have a restoration-driven implant placement. This is true still today. And we want to have a custom-guided tissue healing, as has been pointed out this morning also. And I think this aspect here is very important if we want to get an aesthetic result. And of course, in pros, we still rely on the old checklists that show we look for the midline, we look for the tooth axis, we look for the gingival margin, we look to the scalloping, we look to the zenith of the gingiva, interdental tissue, proximal contact points, to the tooth form and the tooth dimension, interincisal angle, and so on. All these aspects are still true. You can look at them either two-dimensionally or today digitally, also in a way three-dimensionally, because these aspects are showing perfectly the aesthetic frame, and the most beautiful crown is not beautiful if it's not included in a nice soft tissue. Based on old perio literature, you can also realize that the tooth form is very specific. It makes this nice scalloping of the teeth. And of course, the implants today are adapted to the situation too and help to get to these final results. As we have seen this morning, the big problem is that we are losing bone, and we are dealing with the loss of bone. We have to compensate for the bone, to build it up, and do all these surgical procedures to get the minimal soft tissue that is necessary to have restoration that is looking aesthetically. And maybe we have to compensate that also by going a little bit more palatally, by placing the implant. And we have some possibilities today by the angulation, either by the screwdriver or by the abutment, to have the solution that we are planning as a prosthodontic. On the one side, screw retained, today